Okay. Can you see the slideshow now?
Yes.
All right. So for this lecture, we're going to talk about the different types of hernias. Although the presentation discussed the anatomy, which takes a lot of these slides, and then we're going to focus on the hernias that are also important for the exam. Okay. So to start with, hernia. So what's the different the definition of hernia? So is it a defect in the abdominal wall, or is it a weakness? Any idea? You guys can participate as well. Okay. So hernia is a true defect in the abdominal wall. Okay. It can arise from like a weakness to start with. However, there is always a defect in the abdominal wall to start with. Okay. And it's a protrusion of a peritoneal sac. Along with that, there could be also the involvement of the intestines or the colon with it, okay, which is what we refer to as the viscus. Um, so, um, so did you guys get the idea? So we have the layers of the abdominal wall, like from the outermost to innermost, we have first the skin, and then we have the superficial fat, and then after that we have the fascia of the muscles and the muscles. From the outermost we have the external oblique, then internal oblique, then the transversus abdominis. Okay. And after that, we have the peritoneal layer, which lines the abdominal cavity. So the defect that we are talking about is a defect in the abdominal wall, which involves the fascia or the muscle. Okay. And of course, so if there is a defect, then there would be an opening between one cavity to another, or one area to another. So the organs, the abdominal organs, can pass through these defects and then can migrate from a space to another. And then this is what we refer to as hernia. Okay. Hernia has different types. First, we have the external hernia, and then we have the internal hernia. And if the external hernia is incomplete, we refer to it as interparietal hernia. Okay, so the external hernia is the sac, which is the peritoneal sac, that is protruding through the defect, and along with that, so the hernial sac is the peritoneal layer. In addition to that, there could be either intestines along with that or no intestines. So this is we are going to refer to it as hernial sac. Okay. So if there is a defect that is there, and then the sac is going to pass through that defect completely, so we call it external hernia. However, if the defect is there, however, the sac might not be passing through that defect, we call it interparietal hernia. So that the sac is still in the original the cavity or original space before the defect is there, okay? However, there are certain factors that contribute to that internal or interparietal hernia to protrude through the defect. Can you guys think of examples?
Doctor, some people answer in the chat.
Yeah, I can see that. Okay, so increased abdominal pressure, perfect. So, what are the things that can make the abdominal pressure increase? Yes, so we have cuffing and we have pregnancy, constipation. Excellent. Okay, so perfect. So if we have the defect and then we don't have the sac protruding, then factors that contribute to increased abdominal pressure, like coughing, pregnancy, constipation, so or even strenuous activities. Okay, so all of that can increase the abdominal pressure and can make the interparietal hernia to protrude completely. Okay. Then the other type of the hernia, which is the internal hernia, which is like it's not a hernia through the abdominal wall. However, it's through the abdominal cavities. So we have the mesenteric spaces. We have the omental like the omental sac. So if one viscus or one organ is migrating from its original space into another space, and this is like most probably acquired through surgical intervention, so we refer to it as internal hernia. Okay. Okay, so this is next. So this is just a simple picture which shows the of the hernia. So this is the abdominal wall. So if there is a defect through the sheath of the muscles, and then we can have the protrusion of the hernial sac, which contains the peritoneum. Along with that, we have the bowels. Okay, so any questions so far? So next we have the, okay, perfect. So next we have the different types of the hernias. The most common hernias are the inguinal hernias, okay? And then we have the femoral hernia. And in both of these, we refer to them as groin hernias. Other types of hernias, we have the anterior abdominal wall hernias, which contains the umbilical, umbilical hernias, epigastric, spigillian, incisional hernias. So these are considered like very less common than the groin hernias. And we have the rare types, which are the pelvic and the posterior abdominal wall hernias. So all of that we will deal with them, but we will focus more on the groin hernias and then the anterior abdominal wall hernias. Okay. So so this is another image which shows the location of the different types of the hernias. So the groin hernias, which are the inguinal and the femoral, they are located in the groin region, and as we will deal or address them later, they are usually like around the inguinal canal or the inguinal ligament, and the femoral hernia is below the inguinal ligament. Okay. We have the incisional hernia, which is related to like previous surgeries, like they are occurring on top of surgical scars. We have the umbilical hernias, which is like at the umbilicus. We have the epigastric hernia, which is like any hernia above the umbilical line. And the spigillion, as we will address it later, we will talk more about it in details. Okay, so in regards to the hernias, we have to learn certain concepts. So we said about the types, which is the external, internal, and then if the external is there but is not complete, we have the interparietal hernia. Okay. However, there are certain concepts that we need to understand about hernia in general. So although, like, even if we have external hernia, which is the complete hernia, which has the peritoneal sac, and along with that we have the viscus. However, we can either reduce it or it can be fixed. Okay. So the reducible hernia is the ability to return the herniated viscus or tissue, which is the sac in general, to their usual anatomic size. Okay. The incarcerated, which is the fixed one. Okay. The hernial sac with its content is fixed and irreducible. Okay. So it's protruded completely, and now it's considered external hernia, and we cannot reduce it. So we cannot like return the content of the hernia back to its original size. Later, if we have the incarcerated hernia, the incarcerated hernia are subjected to like two major complications, which are the intestinal obstruction, if it has intestines or colon along with the hernia, or if it's if it has vascular compromise, then we call it strangulated hernia. Okay. The obstructed hernia, which is the incarcerated, but it's causing now intestinal obstructions. So the lumen is not continuous. Okay. Here it says not every incarcerated hernia is an obstructed, which is true. So like only a part of the incarcerated hernia has some complications related to intestinal obstruction. The other complication of the incarcerated hernia, which is the vascular compromise, so it would result in ischemia. All right. And this is especially true, like once we are talking about the incarcerated hernia and the complications. It's especially true in the hernias that are running through a small defect. Okay. So if we're talking about the femoral canal and the femoral hernias, or if we are talking about the indirect inguinal hernias, okay? Because they are running through, the indirect is running through the inguinal ring, and the femoral hernia is running through the femoral canal, which is considered a small space. So this is another picture which shows the complications. So we have this a simple hernial sac, so without intestine. So this is considered like there is a defect, okay, and along with the defect, we have a peritoneal sac, but we don't have intestines. So it's still considered external hernia, okay. Here you can see that along with the hernial sac, we have intestines. So now this still like the lumen of the intestines are not completely obstructed. Okay, so this is incarcerated, but there's no obstruction. Now you can see that the lumen is now compromised. So there is intestinal obstruction over here, and as you can see in the image, it shows you that there is some ischemic changes. So there is a compromise in the vascularity. So next, this is another image which shows you the defect through the abdominal wall. So these are just like simple pictures. It doesn't really reflect reality. So there is also another special considerations regarding the type of the hernia. So taxes is referred to the manual manipulation, which is like what we do to reduce the hernia. Okay. The Richter's hernia is the incarcerated or strangulated hernia involving only one side of the bowel. Okay, so we have, as we addressed in the previous lectures of the small intestines, we have the anti-mesenteric side and we have the mesenteric side. Okay, the anti-mesenteric side is usually like the one with the free margin. Okay, and like in terms of vascularity, it always has the less vascularity compared to the mesenteric surface. Okay, so Richter's hernia is only like so this is the Richter's hernia. Okay, so this is the mesenteric side of the bowel, and this is the anti-mesenteric side. So the herniated part is only the anti-mesenteric. Okay, and in addition to that, we have like a risk of strangulation. And why is that? Because of the compromisation of the vascularity. Okay. So you can see over here, strangulation may occur with or without bowel obstruction. And because this is the anti-mesenteric, it always has less vascularity. The sliding hernia, it's a hernial sac which is partially formed by the wall of the intestines. Okay. Yes, it looks like knuckles. Okay. See over here, it says it's either Richter's hernia or Meckel's diverticulum. Okay. Okay. All right. Okay. The sliding hernia is the hernial sac which is partially formed by the wall of the viscus, and usually it's a retroperitoneal organ. So here we're talking about commonly about the cecum and the bladder. Okay. So this is the concept of the sliding hernia. So not only the peritoneal lining, which forms the peritoneal or the hernial sac, but we have also the wall of the viscus, which would form the sac. Okay, and here we're talking about the cecum, because like a part of the cecum is fixed to the abdominal wall, and if it's moving, then it would move also like the large bowel with that. So the large bowel would be forming the sac of the hernia. Okay. Letter's hernia, which is specifically related to Meckel's diverticulum. And a mind hernia, which is specifically related to the appendix. So like any hernia which has the appendix inside, whether intact or ruptured. So it's considered a mild hernia. So this is the middle diverticulum, that is hernia, and this is the amide, which has the appendix. And this is the inflamed appendix as well. So another concept of the hernias, which is the myadal hernia, okay? And always remember it's like a W-shaped hernia, okay? It has two loops, like in the hernial sac, and the middle loop is inside the like the abdominal cavity, okay? So as you can see here, it's a W-shaped. However, there is a risk of like strangulation of this part of the W, okay? However, as you can see that this part is not inside the hernial part itself. So it may not produce a lot of pain due to the strangulation. So that's considered like a major risk factor for deterioration, okay? You can see over here, it's a rare type, but lethal if undiagnosed. And it's more often seen with males. So we have another question, which is strangulation of the part of the abdominal cavity only. Yes. So we have two parts of the bowel, or two loops of the bowel inside the hernial sac, and then in the middle part would be like strangulated. Okay. As you can see here, if the hernia is strangulated, the patient will not only have a tender hernia, but also it will have peritonitis, because as a consequence of the strangulation, there would be like perforation. And like if it's inside the abdominal cavity, then it would produce peritonitis. Okay. So this is considered like a lethal hernia. So these are another images of the mitral hernia. So this is the anatomy of the abdominal wall. So we have a lot of slides in regards to the anatomy, but we will try to make it short. Okay, so on top of these muscles, we have the skin and then the superficial fat. And then we have like the muscles of the like abdominal wall. Anteriorly, we have the rectus abdominis, and like on the sides, we have the like the oblique muscles, the external oblique, internal oblique, and then transversus abdominis. Okay. So we have like a certain aponeurosis and sheaths that are important in regards to the anatomy of the hernias. As we can see over here, the inguinal ligament, which is like a reflection of the external oblique aponeurosis. Okay. Also, we have the linea alba, which we will talk about it later on, which is the like um, uh, the continuation of the rectus abdominis. Okay. Yeah. So we will talk about these later on. So there is also important like differentiation. So at the level of the umbilicus, we have the arcuate line. Okay. And then the anatomy above and below that line would be different slightly. As you can see, the aponeurosis of the muscles. Here above the arcuate line, we have anteriorly like the combination of the external oblique and then the internal oblique aponeurosis. So this would form the rectus sheath. okay, the anterior layer of the rectus sheath. And we have posteriorly what we call the transversalis fascia, okay? This is the aponeurosis of the transversus abdominis muscle. Below that arcuate line, we have like all of these aponeuroses are going anteriorly. And so this is what they form the anterior layer of the rectus sheath, okay? And the transversalis fascia, it would not be supported by the aponeurosis of the transversus abdominis muscle anymore, okay? So this also would play a role in the inguinal hernia, because later on we will see that the inguinal hernias are like a weakness to start with in the transversalis fascia. So the inguinal canal, it's the like reflection of the external oblique aponeurosis. And so the reflection, which is what it formed the canal, okay? However, we need also to address the boundaries of this inguinal canal. So superficially, which is the anterior most part, we have the external oblique aponeurosis. And also through that external oblique aponeurosis, we have the opening of the external inguinal ring, okay? We will see later on some pictures about it. So the superior wall is formed by the internal oblique muscles, the transversus abdominis muscle, and the aponeurosis, as you can see over here. So this is the external oblique aponeurosis, and this is the internal oblique muscle, and then this is the transversus abdominis. So this is superiorly. And we have over here the anterior part, which is mainly by the external oblique aponeurosis. And then this is the posterior most part, which is by the transversalis fascia, okay? And through the transversalis fascia, we have the opening of the internal ring. Through the like external oblique muscle, we have the external ring, okay? As you can see over here. So the posterior wall, which is the floor, which is formed by the transversalis fascia, and the aponeurosis of the transversus abdominis. And this forms the opening of the deep inguinal ring, which is the internal inguinal ring, okay? The inferior wall is formed mainly by the inguinal ligament and the lacunar to some extent. So this is the inferior part. Clear? Any question? And the content of the inguinal canal, which is the spermatic cord or the round ligament. Okay. So this is another picture of the inguinal canal, and this is also another picture. So for the inguinal canal, it's most importantly to understand the inguinal hernias. Okay, so we have a direct one and we have indirect inguinal hernia. In addition to that, so the indirect inguinal hernia is going to run through the internal inguinal ring. So the intestines would go through this opening, and then it will run through the canal, and then it will go out through the external inguinal ring. Okay, the direct one is going to be a defect in the transversalis fascia, and it will go directly into the abdominal wall. Okay, in an area which is called the Hasselbalch triangle. Okay, So we will address the Hasselbach triangle later on. So this is also like another part of the ligaments, which is called the conjoint ligament. So these are important just to understand the borders of the inguinal hernia, okay? So the conjoint tendon, it's a structured from the lower part of the internal oblique aponeurosis and the transversus abdominis aponeurosis, and it's inserted into the pubic crest and the pectineal line. Okay, so this is another image. As you can see, these are a lot of images, but it's not the focus of the of this lecture. Yes, so as you can see over here, this is like another image of the inguinal ring. Along with that, we have the spermatic cord. So as we talked about the indirect like hernias, indirect inguinal hernias, so it can go through the scrotum. Like it can follow the pathway of the spermatic cord, and it can also end up in the scrotum. Okay. So like if you saw like any like intestines in the scrotum, then for sure it's going to be like indirect inguinal hernia. Okay. And there could be also another type of like hernias, which is the obturator, but that's going to be very rare. Okay. Yeah. So this is the superficial, which is the external inguinal ring. And along with that, you can see the hernial sac. So if you saw that, this is indirect inguinal hernia. Okay. Because as we saw, as we talked about, the indirect is going to run through the whole canal, the whole inguinal canal, but the direct inguinal hernia is going to protrude the abdominal wall. It doesn't go through the canal. So these are just definitions of the ligaments in order to understand the border. Okay. So the inguinal ligament is running from the anterior superior iliac spine to the pubic tubercle, and it's formed by the like aponeurosis of the external oblique. So the structures that pass deep to the inguinal ligaments are, so these are the contents: the femoral nerves, the artery and vein, and the lateral cutaneous nerve of the thigh. And it also forms the superior border of the femoral triangle. And inside the femoral triangle, we will have the femoral hernias. Okay. The lacunar ligament, it's a ligament that connects the inguinal ligament to the pectineal ligament of the pectineal muscle near the insertion into the pubic tubercle. So this is going to be important for the border of the femoral hernias. Cooper's ligament, and also it's called the iliopectineal ligament. It's an extension of the lacunar ligament that runs on the pectineal line on the superior aspect of the pubic bone. So this is going to be posterior to the femoral hernia. Okay. And we have also the iliopubic tract, which is posterior to the inguinal ligament, and it's a fibrous tract curving around. So all of these are just like not important for the lecture. Okay, so I'm going to tell you later what's important. We have over here the inguinal ligament, we have the pectineal ligament, and we have over here the lacunar. Okay. So the lacunar ligament would be medial to so the femoral hernias would be over here. So as you can see that the inguinal ligament is going to form the superior border, and we have the lacunar ligament, which is going to form the medial border. And then we have the femoral sheath, and along with the femoral sheath, we have like different compartments. The innermost compartment would be the femoral canal, which is going to have the hernial sac. And lateral to the femoral canal, we have the different types of the femoral veins, artery, and nerve. Okay, so they call it also vein. So vein, artery, and nerve, and vein, which is starting from the medial to the lateral. So the medial most to the femoral canal, which has the hernial sac, is going to be the femoral nerve, the femoral vein. Okay, always remember femoral vein. Okay, so this is also another image of the same concept. And you can see over here, this is what we said. So these are the femoral sheath, and along with the femoral sheath, we have different compartments. The innermost is the femoral canal, and as you can see over here, the lacunar ligament, which forms the medial border of the femoral canal. And later we have the vein, which is like the external iliac, and with that we have the femoral veins, femoral artery, and then femoral nerve. Okay, so always remember the borders of the femoral canal: the lacunar, the medial most, and lateral to that we have the femoral vein. So this is also another image with the same concept. Okay, so once we are talking about the inguinal, so any question about the borders of the femoral canal and femoral hernias? All clear? Okay. So once we are talking about the inguinal hernias, we have to understand the Hasselbalch triangle. Okay. So not only the Hasselbalch triangle, we have to understand the concept of the inferior epigastric vessels. Okay. So I have a question over here. Would the sac cause compression on the femoral vein? Yes. So it depends on like how much the intestines are involved in the femoral canal. And as you can see from the images, the femoral canal is very tight. Okay. So along with that, we have like a very high risk factor for strangulation and also intestinal obstruction. So along with that, there might be also compression of the veins, femoral vein. Okay, going back to the Hasselbalch triangle. So before even talking about the Hasselbalch triangle, we have to understand the concept of the inferior epigastric vessels. Okay, so from the so this is the inferior part of the abdominal wall. As you can see over here, the rectus abdominis muscle, and the aponeurosis over here. And then we have the external or the we have like the deep inguinal and the external inguinal later on. Okay, and over here you can see the Hasselbalch triangle. Okay, so so you can see the borders of the Hasselbalch triangle. The medial most is the rectus abdominis, and we have like lateral to that, we have the inferior epigastric vessels, and like the inferior part of the triangle would be the inguinal ligament. Okay. And why I'm focusing on the inferior epigastric vessels, because the hernia the location of the hernia based on the inferior epigastric vessels would determine whether we have a direct or indirect inguinal hernias. So the direct inguinal hernias, they are going to be located medially to the inferior epigastric vessels. So it's going to be over here in the Hasselbalch triangle, okay? And the indirect inguinal hernias is going to be lateral to the inferior epigastric vessels. And as you can see over here, what do we have laterally? We have the deep inguinal ring. So the indirect inguinal hernias, it's going to start from the deep inguinal ring, is going to run through the inguinal canal, and then it's going to either protrude through the external inguinal ring, or it can even be there in the scrotum. Okay. So clear about this concept, because this is very important. So once you understand this, you can differentiate between direct and indirect inguinal hernia. Clear? All right. So going back to this, yeah, great. Yeah, and the floor of that triangle is composed of the transversalis fascia. So as we said about the cause of the direct inguinal hernia, it's going to be a weakness through the transversalis fascia, and then it can go through directly into the Hasselbalch triangle. Okay. All right. So this is another image which shows the relation of the Hasselbalch triangle to the inferior epigastric vessels and also the deep internal inguinal ring. So the indirect inguinal hernias is going to start from this side, which is lateral to the inferior epigastric vessels. However, we have, and then it can go through the inguinal canal, and this is the opening of the inguinal canal, which is the external inguinal ring. Okay. And then this is the spermatic cord and the scrotum. And we have over here the Hasselbalch triangle, and we have this like area in the abdominal wall. And in that area, we can have the direct hernias. Okay. And as you can see over here, we have also the femoral sheath and the compartments. So this is the femoral ring or canal. And like laterally, we have the femoral vein and then artery and nerve. Another question, direct hernia goes medial to the inferior epigastric artery. Yes. So the direct, again, the direct is going to be medial to inferior epigastric, and indirect is going to be lateral. So these are the types of the inguinal hernias. We have direct, indirect, and we have the combination, which is called pentalon hernia. Okay. So both of them actually are starting with the transversalis fascia. Okay. However, the direct is going to be in the Hasselbalch area, which is Hasselbalch triangle, and the indirect is going to run through the internal inguinal ring, then the inguinal canal, and then it can run alongside the spermatic cord and the round ligament, and we have the pentalon, which is the combination. So whenever we have indirect inguinal hernias, we should also suspect a pentalon hernia. And why is that? Because both of these direct and indirect inguinal hernias are attributed to weakness of the transversalis fascia. Okay, so if the weakness is causing a laxity of the deep inguinal ring, then we can also suspect that there would be weakness that's penetrating the Hasselbalch triangle. So all of these are just images which has the same concept. So now let's talk more in details about the indirect or inguinal hernias. So as we said, these are the most common types of hernias, and it contributes to 80% of all types. And males has like more predominance in this inguinal hernia. So as you can see, there is a large difference between male and female. However, still, like in females, we have the most the more common type in females is still the inguinal hernia. So you can appreciate how rare are the other types. Okay. In men, we have the direct happening more than the indirect in a ratio like 2-1. And the likelihood of incarceration is attributed to the small caliber or the small canal that's passing through the hernia itself. So in that regard, we have the femoral canal and we have the inguinal ring. So of course, once we are talking about the inguinal hernia, the likelihood of incarceration would be more in the indirect hernias. All right, so this is another slide which talks about the content of the spermatic cord, okay? And as you can see, like we have 5 different components, and then the 6th one, which is the hernial sac. And remember, only if it was indirect hernia, okay? So if a hernia was there in the scrotum, then always remember indirect hernia. So these are the etiologies or the causes. I have another question. Indirect must go through both the internal and external rings. Yes, both actually. So it can go both. It will run through the whole canal, and then it can protrude through the external inguinal ring, or it can be there in the scrotum. All right. So these are the causes of the inguinal hernias. We have, like embryologically speaking, we have the lack of obturación of the process vaginalis. Okay. And like the most common type, which is or the most common cause, which is the weakness of the transverse fascia. Always remember that. And these are the other causes that can contribute to the etiology. So we have muscle weakness or deficiency, prematurity, low birth weight. All of that would cause weakness of the muscle. Okay, wear and tear, stresses of life, and especially with that we have the multiparity, we have the obesity, advanced age. Okay, and cigarette smoking. So all of that would cause weakness of the muscles. So what would be the clinical presentation? So it's going to be like bulging. So whether it is fixed or not fixed, or it's the external complete hernia or the interparietal hernia. So it's going to be intermittent or fixed bulge. Okay. In males, hernia may extend into the scrotal sac if it was indirect. And patients may describe minor pain or big discomfort. So like the initial presentation would be like this one, vague abdominal or groin discomfort, okay? And the bulging, always remember, it's going to increase with the intra-abdominal pressure. So we always, once we like examine the patient, we ask the patient to cough in order to see like if it's bulging or not. Okay. This is to confirm that there would be a hernia. Rarely patients can present with the paresthesias. Paresthesias may later present with the repair of the hernias because, as you can see in the contents of the spermatic cord, we also have some nerves, the genitofemoral, we have the hypogastric, and all of that. Okay, so once we repair the hernias, we have to take note or we have to take extra care of the nerves in order not to complicate the surgery. Okay. We have also symptoms related to exertion or long periods of standing. So this would increase the discomfort and discomfort feeling with or without a mask. Okay. Physical examination is best examined while standing. We ask the patient to cough or do a Valsalva maneuver in order to increase the abdominal pressure. And the bulge is usually smooth, rounded surface. Okay. There would be also invagination of hemiscrotum and introduce the index finger through the external ring in order to see like if there is bulging or not. Okay. All right. So these are the differential diagnoses of the or the inguinal hernias in general. Okay. So we have the femoral hernias, which is the second most common after the inguinal hernias. But this one is going to be below the inguinal ligament, as we saw in the anatomic pictures. We have also inguinal tendinopathies, which is related to like the benign tumors, okay? Lipomas, dilation of the saphenous vein, epididymitis, testicular torsion, groin abscess, vascular aneurysms. We have to exclude testicular torsion and epididymitis because they are considered emergency cases. Okay. A hernia in the scrotum, so it's indirect except for obturator hernia, which is very rare. Okay. So these are also complications of the hernia repair, as we said. So we have ischemic orchitis. So things that are related to the spermatic cord, ischemic orchitis, injury to vas deferens. We have also hydrocele, osteitis pubis, wound infection, hematoma, or nerve injury, neuralgia and nerve injury. And it can also be recurrent hernias. Okay, so if it wasn't sutured completely, then we have also another weakness of the abdominal wall, and then it could lead to another hernia. So these are the nerves. So we have the ilioinguinal, which supplies the pubic region, which is mainly the base of the penis and upper scrotum, and also upper and medial part of the thigh. So these can be injured through the surgery. We have the iliohypogastric, and this supplies the skin over the pubis. We have the genitofemoral nerve, which is like L1, L2, which supplies the cremastric vessels and the innervation of the scrotum. So going to the femoral hernias, okay? So as we said, the femoral hernias, they are going to protrude through the femoral canal. And always remember the borders, the boundaries of the femoral canal. So medially, we have the lacunar ligament, laterally femoral vein. Anteriorly, we have the iliopubic tract, and posteriorly, we have the Cooper's ligament. Okay. And they are more common in females. However, still like the commonest in females would be the inguinal hernias. Okay. As you can see, the ratio is 2:1, or now it's becoming 3:1. Um, and more likely, it's going to be incarcerated. And why is that? Because the femoral canal is narrow. In females, indirect hernias are more common than the femoral hernias, as we said. The hernia will protrude through the femoral canal into the upper thigh. Okay. And these are the boundaries that we talked about. So this is the bulging of the femoral hernia. You can appreciate that these are the area of the inguinal ligament. Okay. So that is going to be below the inguinal ligament. And this is another repeated picture. So this is like a differentiation between the indirect and the femoral hernias. So we have over here the inguinal ligament, and along with that we have the inguinal canal. So, and then we have a hernial sac which is running through the inguinal canal. So that would be indirect inguinal hernia, and this is the femoral hernia, okay, which is running through posteriorly, like or yeah, inferior to the inguinal ligament. Okay. So all of that is just a like a repetition of many pictures anatomically. Okay. So the symptoms would be like intermittent groin bulge, and may present with symptoms related to bowel obstruction. And in addition to that, we have a physical examination would reveal a small rounded bulge in the upper thigh below the inguinal ligament. And the bulge may be firm and tender. So if it was tender, then you need to suspect there would be incarceration. There would be, in addition to that, strangulation. So this is the treatment of the femoral hernias. So for the treatment, you don't have to like memorize any of these, okay? Just understand the concept and how to differentiate between the different types of the inguinal or even femoral hernias, okay? All right, so these are the like another picture which shows the location of the different types of hernias. So we're talking now on the about the incisional hernia, which is like a hernia which occurs on top of the previous surgical scar. Okay. So the contributing factor to that would be like anything that would also cause weakness to that area. So obesity, as it will like put a lot of pressure on top of the abdominal wall. We have also wound infection, which would render the wound healing, and it would not make the healing of the wound perfectly. We have also malnutrition. We have smoking. We have technical errors in the wound closure. We have also, like more commonly, it's seen in the midline incisions. And if in the midline incisions, these are going to be the most hernias to reoccur. Okay, and in addition to have to these factors, we have also the what we say the advanced age. So the most important risk factor for the femoral hernias, always remember, it's going to be the advanced age. Okay. In addition to that, so we said in the femoral canal or the femoral hernias, it's more common in females. So after the advanced age, we have to consider also the multiparity. Okay, because these are the factors that are going to make the femoral sheath lax. Okay. So these are the ventral hernias. The ventral hernias has like a special concept is that there is a hole in the muscles of the abdominal wall. Okay, so like the muscles of the abdominal wall are separated with a space, and this space would create another space for the hernia. Okay, so this is the concept of the ventral hernia. The umbilical most commonly it would be congenital, okay, and they would present at earlier ages. However, they can still present with advanced age, especially like if it was small, okay. But however, like if they are small and then with advanced age they are going to be larger, then they can also contain the hernial sac. So, like if they are increasing in size, then we have to repair it because there would be also risk of incarceration later. So they are more common in females and more common in African Americans. Um, they may not present till adulthood, okay, as we said, because they would be of small caliber. Small umbilical hernias can present for years but unnoticed. The small umbilical hernias are usually asymptomatic, okay? And then they tend to enlarge with time. So the epigastric hernia is going to occur at the linea alba, okay, which is the line of the rectus abdominis muscles continuation, okay? So that's going to be above the umbilicus. It's occur more frequently in young athletes. So always remember two things about epigastric hernias. Young athletes above the umbilicus, okay? And there is also another thing that may be confused with the epigastric hernia, which is called the diverification of the recti, okay, which is not a true hernia. So this is like it's a gap between the recti muscles, and they are more commonly in females and special risk factors, the multiparity, okay, and they are considered as a cosmetic issue. So the treatment with that would be the approximation of the recti muscles. So it's defined as the gap or separation of like 2.5 centimeters or more between the medial edges of the recti muscles. So it's not a true hernia. It's not a true defect. However, like there is just a space between them. Okay. So they may be confused the diverification with the epigastric hernia because the epigastric hernia is a true hernia. Okay. Another type of hernias, which is called the spigillin hernia. And the spigillin hernia is it's located at the linea semicircularis, okay? Or linea semilunaris, okay? And this is the line before the linea alba, okay? So it's going to be over here at this line. So it's between the recti muscles and the oblique. As you can see, it's over here. So, in regards to this type, you only have to know like the location. Okay. So these are all like images of this defect. And then we have the rarer types of the hernias. So we're going to talk about the lumbar hernias. So in regards to this type, also you just have to like memorize the location, okay? because these are very rare types of hernias. So we have two different locations. So these are in the posterior wall of the abdominal wall. Okay, so it's not in the anterior wall; it's in the posterior wall, as we will see. So here we have two locations. We have the petit triangle, and we have the Grenfell triangle. So this is the petit triangle, and you can see over here the inferior border would be the oblique or the iliac crest. We have the external oblique, which is laterally, and we have the latissimus dorsi medially. Okay, and for the Grenfell triangle, we have like the upper lumbar area, which is bounded by the 12th strip, which is this superior part, and we also have the external oblique, but it's going to be on the lateral part, and also like we have like borders like the internal oblique muscles and the sacrospinal muscles. And then later on, it's covered by the latissimus dorsi. Okay. So just remember the borders, and here like it's there in a beautiful table. Okay. And then we have the obturator. Obturator, remember that it occurs predominantly in thin older women. Okay, so it's more common in females and specifically in older women. Okay, and like they are of the Richter's type. So do you remember what we said about the Richter's hernia, which is the the antimesenteric involvement? So they're also at risk of the strangulation. Okay, and like how to physically examine them, these patients. We have the Hauscher-Romberg sign. Okay, which is like if you do a medial thigh rotation, there's going to be a pain along the medial aspect of the thigh, which is the obturator nerve compression. So this is the medial rotation, and then there's going to be a pain over this medial aspect of the thigh. Finally, we have the internal hernias. So internal hernias, just remember that it's going to be it's not involving the abdominal wall anymore. However, it's inside the abdominal cavity. So like it's a migration of certain organs from one space into another inside the peritoneal cavity. Okay. You don't have to memorize all of that. So the causes. But like if it's acquired, like most probably it's going to be due to like surgical repair, okay, or ostomy formation, okay. So like these are different types of the internal hernias. So these are different spaces. So organs can go from one space to another. Okay. And that's it for this lecture. Any question? Okay. So, Dr. May you please explain the difference between three types of hernia in the first slide again? Okay, so we will go to the first slide. So you mean this one? Okay. All right. So as we said, the external hernias, they are going to be a protrusion through the abdominal wall, as we talked about the layers of the abdominal wall, of the muscles, the aponeurosis, etc. Okay, so it's going to be a defect through that abdominal wall, an opening, and then through that opening there would be the protrusion of the intestines. Along with that, we have the peritoneal layer. So it will migrate from the abdominal cavity into the abdominal wall. Okay. So this is the external hernia. And in addition to that, we have the interparietal, which is the same defect of the external hernia. However, in the external hernia, we have a complete protrusion. So in that defect, we have the hernial sac, which is out of the abdominal cavity into the abdominal wall. However, the interparietal, there is only the defect that is there. But however, the content might be there, the hernial sac might be there, might be not, okay? So it's not completely protruding. What make it protrude is the increased intra-abdominal pressure, okay? And internal hernia is not a defect through the abdominal cavity, but it's not a defect through the abdominal wall. It's a defect in the like the mesentery, okay? And like as you know, like there are different compartments inside the peritoneal cavity, and what determines these compartments is the mesentery. So there would be migration of the organs from one compartment or one space into the other, and that's either going to be congenital defect or a surgical manipulation. Other questions? You're welcome. All right. Any other question? Okay. So shall we begin with the revision?
Yes, thank you.
All right. So what do you need from the revision? So my notion is that you want to revisit the concept of the post-gastrectomy syndromes.
So there's mainly 3 topics to review: the gastrectomies and post-gastrectomy syndromes, gastric neoplasms, and approach to abdominal pain. And then if it's possible, we can have like an overall important points we should know from every lecture.
Okay. So what I want you to understand, so in regards to the last point, I'm not going to be involved directly in the questions of the exams. Okay. So I cannot give you like a great idea about the examination, how it would be. Okay. If I was involved in the questions, then I can tell you that focus on that, focus on these, etc. Okay. But since I'm not going to be involved, I don't want to mislead you. That's the whole idea. So let's revisit the concepts that you guys need to revise. So that's going to be better. Okay. And I'm going to also try to make another session for you guys in regards to like some like MCQ revisions. Okay. You guys took already the midterm, right? Of the GI. How was the question?
There isn't a midterm for GIT. It's just.
Oh, so no midterm in the GI. Okay. I see. Okay, so then we may have another session of the MCQs. We can reschedule it later. Okay. But so first, which which lecture you want to start with?
We can start with the gastrectomy, then post-gastrectomy.
Okay, you can share the slides.
Okay, 1 second.
Mhm. Take-home message of the presentation. It can be summarized in 3 to 4 lines. Okay, so don't be like misled by the like amounts of the slides and all of that, because as we said, like most of these slides were about anatomy, and the anatomy, like we can explain it in one picture. Okay, so I don't think like it's too much. However, you need to organize the information. So the surgeries are too many, and do we need to focus on it? No, you don't have to. However, since we are talking about the the surgeries and all of that, so as you can see in this presentation, it's the post-gastrectomy syndromes. So we are not asking you about the procedures themselves. We're going to ask you about the presentation and how to like differentiate between the different types of the syndromes. Okay. So it's not the surgical aspect or surgical part itself. However, it's the syndromes. Okay. So can I control the presentation?
I don't think that's possible, or at least I don't know how to do that.
Okay, so let me try to find it. I'll share it from my side. See it?
Yes.
Yes.
All right. So you guys need like a revision of the whole presentation, or there are like certain questions? So let's start briefly, like reviewing this presentation. We have like these pyloroplasty procedures. So of course, and definitely, we're not going to ask you about the like the types and the names, okay? And we're not going to ask you about the types of incision and all of that. So we can skip this part. And what we are concerned about is these syndromes. So Billroth 1, Billroth 2, the complications of these procedures, okay? So what do you remember from the complications of Billroth 1 and Billroth 2? So from Billroth 1, we have like the elementary limb, right? If you guys remember. Yes, we have dumping syndrome, okay? And yeah, the early and late, yes. So in Billroth 1 and Billroth 2, the difference is that like the area of the stomach involved would be like the area that we excise from the stomach would be more with Billroth 2, okay? And also there would be an elementary limb and which what we call also the mixed limb and the biliary limb as well, okay? And this duodenal stump. So this is what we call a gastrojejunostomy, okay? And this is gastroduodenostomy. So these are the two different like differentiation between Billroth 1 and Billroth 2. And accordingly, so since we are removing a major part of the stomach, so the complications with the Billroth 2 would be more common, okay? And we have also the Roux-en-Y procedure, which is like removing like most of the parts of the stomach. And also we have the biliary limb and the alimentary limb. Same concept as the Billroth 2. So what we are concerned is, as you guys said, is the dumping syndrome. So the dumping syndrome is happening because of we are losing the function of the stomach. Okay. Where are the limbs? Where are the limbs again? So again, like you don't have to like focus on the concepts of the limbs. But remember that with Billroth 2, it's going to be similar as Roux-en-Y. So they have two different types of limbs, which the one which is like connected to the stomach, we call it the alimentary, okay? And the one which is connected to the pancreatic duct and the gallbladder, we call it the biliary. And then they mix together, so they would form the mixed limb, okay? So once we have these limbs, we have also like the complications with that. Okay, as you can see over here, it's more like most common after Billroth 2 reconstruction. So like most of these syndromes are related to the procedures of the limbs. Okay, so the most important is not the limbs, the how to understand dumping. Okay, dumping syndrome. So it's happening because that we lost the reservoir function of the stomach. Okay, and as a consequence of that, there would be a fast transition of the luminal content of the stomach into the small intestines. Okay, and usually what's going to be there in the stomach is that like whatever food is there is going to be forming a juice. So it's not completely like hydrolyzed or metabolized. It's only forming a smaller like molecular aspect. Okay. So with that, we are also losing this. So what's gonna reach the small intestines is the high osmolar carbohydrate load, which is causing this dumping syndrome. Okay. And this dumping syndrome is characterized by the early or late dumping syndrome. So it's two types. The early is related, so it occurs within 30 minutes of eating, okay? And it's related to the rapid extra fluid shift into the bowel lumen, okay? And why is that? Because of this high osmolar carbohydrate load, okay? So there would be a high concentration of these food, and then as a consequence of this concentration, like water is going to move down gradient, and then there would be extracellular fluid shift. So as a consequence of that, the major characteristic of the early dumping syndrome is explosive watery diarrhea. Okay. And in addition to that, so we're losing a lot of fluid. There would be also symptoms related to dehydration, like dizziness, palpitation, fasting, and diaphoresis. So this, we call it vasomotor symptoms. The late one, which presents like hours after eating, and this is related to the hyperinsulinemia of that high osmolar carbohydrate load. Okay, So it's not the amount of the carbohydrate that's there. However, like what's reaching the small intestines is large, and the small intestine is not realizing that this large concentration is not a large amount. Okay, so it's going to stimulate the pancreas to produce a lot of insulin, and it would result in hyperinsulinemia. Okay, so as a result of hyperinsulinemia, there would be the symptoms. So symptoms would be related to hyperinsulinemia, like reactive hypoglycemia. Okay, so if you measure the blood sugar, it would be below 80. And also symptoms would be related to that. So there would be sweating, tachycardia, dizziness, loss of concentration, and all of that. So how to treat with the late dumping? So initially, you give them additional carbohydrate in order to resolve the hypoglycemia. Okay, but you have to like follow certain etiquette in order to avoid the development of the early and late dumping syndrome. Okay, so how to avoid the early and late dumping syndromes? By eating small and frequent meals. Okay, so you avoid larger volumes of the meals, but you supply the patients with sufficient nutrients. Okay. In addition to that, liquids should be avoided or should be ingested 30 minutes after eating solids. Okay, not along with the food. All right. Why is that? Because we need to like decrease the concentration. We need to like juicify the food. Okay, but not to make it in larger volumes. Okay. Simple carbohydrates should be avoided because that would increase the load of the carbohydrate, which is causing the dumping syndrome. And also the use of octreotide may contribute to the resolution of the symptoms of the dumping. Okay. And if it's producing like more and more of these symptoms, then you may convert like the procedure, which is build 2 into Roux-en-Y. But again, the last two lines are not of importance to you guys. So you have to understand the third lines, okay? The first 3. All right, so this is again like the differentiation between the like early and late dumping. So this is all we explained right now. So we have also another complication, which is the alkaline reflux gastritis. So from the name, so it's the alkaline juice or the alkaline products of the small intestines going through the stomach and causing inflammation. Okay, and why is that? Because we lost the function of the pylorus sphincter. Okay, so the mucosa of the mucosa of the stomach is not handling the alkalinity. So as you know that the mucosa of the stomach is like يعني it's more protected with the acidity. Okay, so the alkalinity will cause also ulcers. Okay, so increased acidity and alkalinity would also injure the mucosa of the stomach. So it's producing the triad of the epigastric pain, nausea, and bilious vomiting. Okay. So the question is, this is seen more with Billroth 2 or Rho and Y. What do you think? So again, yes. So Billroth 2 has more like complications in general than Rho and Y. Okay. Why is that? Because like from the images you can see, so this is Rho and Y. Okay. And in Rho and Y, we avoided the connection between the biliary gland and the stomach. Okay, so they are not going to connect. But however, in Billroth 2, where is it? Yes, in Billroth 2, the intestines would be connected to the stomach. So the alkaline gastritis can happen anywhere in these regions. Okay. However, in Rho and Y, it's very like uncommon to happen. All right. So the diagnosis endoscopically and all of that, you don't have to know. Okay. Um, so so about the diagnosis and like surgical management, you don't have to know as well. So bile reflux can be confirmed by HIDA scan. This is not important for you. Okay. Treatment. So the non-operative would be also like more frequent meals, antacids, and cholestyramine in order to reduce the alkalinity. Okay. Also, why are we using antacids? In order to protect the mucosa from ulcerations, ulcerations from the acid. The operative, as you can see, that we will convert the Billroth into Rho and Y. So this is how to convert, but of course, this is not important for you. So marginal ulcers can happen anywhere with like with the stomach connections. Okay, so this is related to surgical complications. Okay, also it's called stomal ulcers, and it's related to incomplete vagotomy because there's still like innervation or like acid production innervation from the vagus nerve. Okay, and it's also related to retained antrum. Okay, but it can happen with any surgical procedure actually. There's it's all marginal ulcers, so like even like the areas of suturing, it would be at risk of these ulcers. Okay. See, the last part over here, marginal ulcers is related to the acid production, usually at the anastomotic site, not in the stomach, more commonly in the jejunal part. Retained antrum, this is the presence of the remnant part of the antrum. And the retained antrum is continuous with the duodenum. This is related to the like gastritis of the alkaline reflux. Okay, because there is like part of the stomach that's there, which is at risk of like ulcerations. So that's mainly it. The antrum doesn't have much of a function. The loop syndromes, the afferent and afferent. So again, so it happens more frequently with Billroth 2. So it's of two types, the afferent and efferent. So what do you know about the afferent and the efferent loops? So do you guys study these lectures already, or you're going to study from this week? That's the question. All right, so okay, so I have an answer over here. Afferent is non-bilious, efferent is bilious. So it depends. Let's revise the anatomy after the afferent and efferent loops. Right. Afferent has acute, and chronic. So this part is very important. It differentiates between the acute and chronic type of the afferent, the efferent as well. Okay. So acute, of course, it's going to happen a few weeks after surgery. The chronic, it takes like months to years, especially in the efferent. Okay. And the part of the afferent, it's months after surgery, and it's related to partial mechanical obstruction. Okay. So the acute is non-bilious. However, the chronic, it's also like it's going to be postprandial right upper quadrant pain, which is relieved by bilious vomiting. Okay, that's not mixed with recently ingested food. So even with the afferent, we can have bilious. So not only the efferent, it's going to be the bilious emetic. Okay. Okay. So it's going to be related to obstruction. It's either by king or dilation. It's as we took in the previous lecture. And also, it could be stenosis of the anastomotic sites, and also be attributed to twisting of the limbs, or it can be due to lesions. Both that are causes of obstructions. Okay. So these are the symptoms. So non-bilious vomiting and severe abdominal pain. That's true for the acute one. Okay. So lab findings were elevated bilirubin and amylase, duodenal stump. So with the obstruction, as you can remember, that duodenal stump would be at risk of opening over here. Okay. So as a result of increased pressure. So that can be the perforation, peritonitis, abscess formation, and fistula. Okay. And in the urgent setting, they tell you that jejunal anastomosis have to decompress. Also, this is not very important. Is it correct that the absorption can cause blind loop? Yes, the blind loop is to like the overgrowth of the bacteria. Okay, so as a result, like as you know, if there is any obstruction, there would be the like a bacterial overgrowth, and it can lead to blind loop syndrome. Okay. So vomiting doesn't contain food through the efferent limb. Okay. noise. Okay. So, they tell you that food is not there, is going to be in the efferent. And you need to understand something. Okay. So this is loop, this is okay. This is the afferent, efferent. The efferent, it has food with it. The afferent, it doesn't. So this is what it has the next one. It's like food along with the biliary juice. But the afferent doesn't have food, right? See, vomiting doesn't contain food, it passes through the efferent. Vomiting relieves the pain, and bilious vomiting with afferent loop indicates or chronic, as we said. The E is intermission of the efferent lymph is characterized by the abdominal and bilious vomiting. So duodenal stump, as we said, it's related to the obstruction of the under pressure. It can lead to also bacterial overgrowth, which is the blind lobe syndrome. Okay, so stasis of resulting in like if there is bacterial overgrowth, then so steatorrhea, vitamin B12, folate and iron deficiency, and why is that? Because bacteria is going to compete with the gut for the absorption of these of these micronutrients. Okay. All right, and well, because we as well. So state of the afferent, though that the afferent has by because right after surgery there is isn't going to be like time for like patients, they're going to be NPO first of all, okay, and they would take time and to like go back to like the normal eating, and then or you would not see the biliary emesis in the afferent loop syndrome, okay, because we don't have the stimulus for that. But however, the chronic form, then the obstruction and food is going to be there. The stimulus for the biliary tree is going to be there. That's why you would see the vomiting or the biliary emesis. Yeah. So this is a few weeks after surgery. Okay. So treatment would be like to remove any obstructive causes. Like if there is adhesion, we have to remove these adhesions and so on. Okay. And if it's necessary to convert biliary to Rho-NY. Okay, next. Duodenal stump. So we already mentioned that. So it occurs 3 to 10 days post-op. And most common cause of mortality amongst all like post-gastrectomy syndromes, and it's caused by blind loop, technical error, or compromised blood supply. So even like stasis of the intestines and then bacterial overgrowth can contribute to the duodenal stump. Post-vagotomy diarrhea as you guys know, with any like surgical procedure of the gastrectomy, we tend to do like to a certain level bigotomy in addition to that, because we need to reduce the acidity. Okay. So if there is extensive bigotomy, with that we will lose the peristaltic movement. Okay. So there would be vagal denervation of the small bowel and biliary tree, and there is going to be like watery episodic diarrhea, which is unpredictable. This is very important. So this is the characteristic, and usually when they say to you unpredictable, then of course directly think about bigotomy. Okay, so this is not related to food, unlike the other symptoms, the other syndromes. Okay, and these they improve with time. There is no like definitive treatment for that. However, there might be supportive treatment, which is also like not important for you at this stage. So you have to focus on these 2 points: watery, unpredictable, not related to food. Yes, but so I have a question here. It says that how does bigotomy cause diarrhea? It shouldn't cause constipation. So there are like different reactions of the body in regards to like bigotomy. Okay, it all depends on the how much bigotomy did we use or did we make. As you guys know, like in the nowadays in the surgical interventions, we have something called highly selective bigotomy. Okay, so highly selective bigotomy, it can go to the area in which we need less innervation, in which like we don't produce more acid. Okay, and then we denervate that area. So this is called highly selective. Okay. We have like extensive bigotomy, we have truncal bigotomy. So it all depends on the level of bigotomy that we did. And then later on the effect of that part of the bigotomy. So if we do truncal bigotomy, then the whole aspect of the GI tract would be paralyzed. We will lose the peristaltic movement. There will be constipation and so on. Okay, but if you do more of the extensive rather than the vagal one, okay, or the truncal one, then you would lose only the function of the glands or the secretions, but you don't lose the functions of the motor. Okay, and usually the ones that we are talking about, the secretory part, is related to the myenteric plexus, or yeah, it's related to the plexus of the gut. Okay, so it's not related to the truncal, which is the peristaltic movement. Okay, so that's why episodic watery diarrhea. But again, you don't have to like focus more on and why and how. You have to pick it up. So if it's watery, unpredictable, not related to food, then this is post-bigotomy diarrhea. Okay, so this is Roux stasis syndrome. So this is related to Roux-en-Y procedures, and it's characterized by chronic abdominal pain, nausea, and vomiting, aggravated with eating. So all of that, all of these loop syndromes and dumping, like more often it's associated more with the Billroth procedures. So this is related to Roux-en-Y, okay? So this is aggravated by eating. It's caused by functional, non-mechanical obstruction, okay, of the rulum proximal to the duodenum, okay. So due to disruption of the normal propagation of pace-setter potentials in the rulum, also associated with altered motility of the gastric remnant or pouch. So this is related to also like the innervation and manipulation, surgical manipulation, and like the disruption of that. So the consequence of that to the motility. Gallstones, and why is that happening? Yes, so it's not important. We said like in the class, this is not of importance. Okay. So the important ones, as we said, the dumping, the loop syndromes are very important. The duodenal stump is very important as well. The post-vagotomy diarrhea, this is also very important. Row stasis is not really important, okay? So gallstones secondary to vagal denervation of the gallbladder, so it would cause stasis and development of gallstones. Early satiety, so this is related to like losing like a high volume of the like the stomach. So this is like as an example of the gastric sleeves and Roux-en-Y. So we do these procedures in order to cut down the volume of the stomach. Therefore, patients will have like early satiety. They can't eat like large volumes, and then therefore they would lose profound weight. But in addition to that, there would be malnutrition, which is supplied by supplements. Okay. Gastric fistulas. So with any surgical procedures, there would be also as a complications fistulas. Okay. So this is the concept that you need to take from this. Chronic gastroparesis, which is chronic delayed gastric emptying or gastric remnant emptying without mechanical obstruction. So as we said, like the antral part of the stomach doesn't have like that much of a function, but it may lead to also gastroparesis, okay? But this is not important. Nutritional disturbance, this is in general, like as the concept of the weight loss. So this is important. B12 deficiency, why is that? Because we're losing the intrinsic factors, iron and folate deficiencies, which is normally absorbed in the duodenum, calcium and vitamin D, which is in the proximal ileum. Okay. The weight loss. So this is the major aspect of these procedures. So related to early satiety or the gastroparesis, either due to like, the antral part remnant or the vagotomy, okay. Anorexia due to loss of ghrelin hormone, which is responsible for the hunger. Malabsorption, dietary modification due to dumping or diarrhea, okay? So that's it. You just have to take the concepts of the loop syndromes and dumping. After that, everything makes sense. Any other question related to this presentation? Nothing? So what else after this?
Gastric neoplasms and approach to abdominal pain.
Approach to abdominal pain. Okay.
Doctor, if you want, you can just, if anyone has any question on them, they can ask instead of going through the whole.
Yeah,
Mhm.
exactly. So that's going to be more beneficial, actually. So if you guys have any question, it's good. We could address it right away. So approach to abdominal pain. So this is the one.
Yes.
So approach to abdominal pain is a general like a theme. Actually, it's not something that you guys will take in one lecture and that's it. As we said, it has like so many related slides in regards to anatomy and the differentiation between the visceral and parietal pain. This is all general concept, okay? However, later on, we will see like certain differential diagnosis. Over here. So you have to understand like most of the questions is going to come as clinical scenarios, okay? It's not going to come through direct questions. So if there is any question that is coming from this presentation, it's going to be direct. So I think, therefore, like no, like there's no like specific questions related to this presentation. Okay. The idea of this presentation is to understand the referred pain. So if it comes as like a part of clinical scenario. So let's say one of the scenarios that I tell you about is an epigastric pain that's radiating to the back. So what's the first thing that you guys will think of? Any answers? Pancreatitis, exactly. So this is what we mean about referred pain. So this is epigastric pain radiating to the back, which is pancreatitis. Pancreatitis has like a whole different lecture, okay? So again, like the concept of this lecture will come as part of the questions, but there is no specific question related to that presentation, okay? So the idea of it is that you have to understand the referred pain. For example, we have the right upper quadrant pain, which is radiating to the right shoulder. Then this is going to be problems related to the gallbladder or the liver, okay? But like mainly it's going to be related to the gallbladder, okay? Appendix problem. So like if it started, usually it starts like very umbilical and then it goes like more specifically to the left lower quadrant, okay? You have to understand this because it will help you to answer like the questions correctly, okay? So this is a fundamental lecture for you in order to understand how different cases would present. However, there's no nothing I can take as from this slides that are specific to certain topic. You got me? Like, see, it's all related to history taking and physical examination. So if you have any question, I can answer it to you. But if you want me to focus on like different things of this presentation, I cannot really. So maybe these signs of physical examinations you guys also covered in the professional skills. It's going to be also important, like how to elicit and all of that. But is there anything specific that you guys need to know? Maybe from these images, like if you see the standard bowel, and then distally there is an obstruction, proximally there is the standard bowel, then this is like intestinal obstruction. Okay, this is obstruction of the intestinal loops, and also there is like another. So if you see a Haustra formation, as you can see over here, this is a colonic obstruction. Okay, but if you see on the like loops of bowel that are obstructed, this is intestinal obstruction. Okay, air fluid level, also it would reflect there is an obstruction. So these are distended loops and air fluid levels. So this is related to bowel obstruction. What else? So these are the Haustra that you can see. So it indicates the large bowel obstruction. And this is air under the diaphragm. And air under the diaphragm indicates perforation. And if there is perforation, there is an immediate surgical indication. Okay. So this is a free intra-abdominal air with the Ryler sign, which is like the enhanced borders of the wall. Okay, with air with the bilateral contrast, so intra and extraluminal air contrast. So pneumatosis, we said it's related to so it's air inside the wall of the intestines. Okay, so it's related to ischemia, and also it's related to bacterial overgrowth inside the wall of the intestines. Okay, so this is pneumatosis. You can see it from clean radiograph. Other than that, so these are all like differential diagnoses that you guys don't have to like memorize it. However, you have to appreciate it with the time, because like if there is any information that can help you with the clinical scenarios. However, there's no definitive answer from these part of the presentation. It just helps you to understand the rest of the block. Exactly. So any question related to this? So shall we move on to other presentations? If you guys want.
The last one is gastric neoplasm.
Last thing is what?
Gastric neoplasm.
Gastric nutrition. Okay. So it's a like 100+ slides.
We can also do this
Well,
in a question. Then
yeah. So if you guys have any specific questions related to that. This part of the presentation, they talked about the benign and the malignant tumors. Okay, the polyps and all of that. So this is probably like one topic that you guys also took in the pathology, right? Did Dr. Oban or Dr. Abrar give you any presentation about this?
yeah, we took a patho lecture.
Yeah, so that's going to be very similar to the pathology, actually.
Okay.
Even Krakenberg's tumor, right? You guys took it, I think, with Dr. Abrak, right? So in regards to like TNM staging of any malignancy, you don't have to know it, okay? However, you need to take the concept of the TNM staging, which um, similar to what you guys took in the lectures, okay? So all what you need to know about TNM staging is this slide, okay? What T, what N, what M indicates, okay? I think in the pathology they would also ask you about like the concept of the T0, in situ, and all of that. However, like if it comes to like a certain malignancy, you don't have to know it. You just have to understand the general concept of it. But the specific TNM for each cancer is not important. Okay, and even like the treatment, surgical treatment, and all of that is not important for you. So what's left this presentation actually be very similar to your pathology. So do you have any questions related to like a specific PowerPoint? Did you guys take even the benign neoplasms in pathology? So there is a question. Do we have to know the specific site for example, for GI carcinoid? It's the end. Yeah, if that's addressed in the pathology lectures, then yes. Like in presentation on carcinoid tumors. But if we're in the pathology lectures, of course, you have to take care of that. Any other? See, when it comes to carcinoid, it's all about pathology. Histopathology, clinical presentation. Investigations and treatments, you don't have to focus on that. Okay. Did you consider these two patients? They are vague. Like you guys actually don't know what to focus on from the neoplasia and the abdominal pain. However, like topics of the GI system. So the other topics I would classify them as more than these. Okay, so this should be easy and straightforward. There's nothing clinically important or relevant except pathological aspects. Right? So as regards to other lectures as well.
That's it. Thank you very much, Doctor.
All right. So I'll let you know about the MCQ session.
Okay.
So if we can arrange it in like tomorrow or the day after, that would be good.
Okay, perfect. Thank you.
Okay.
Yeah.
All the best.
Thank you very much, doctor.
Thank you.